الأولانية وأرحب بيكم تاني طبعا. هو أنا يعني actually this presentation is a merge between the presentation of my thesis, my MD thesis, and the other applications of whole body MRI. My MD thesis was a comparative study between whole body MRI and bone scintigraphy in the detection and the detection mainly of metastatic bone lesions in breast and lung cancer. So we are going to start by this question, and hopefully we will reach an answer at the end of this lecture. Every day we are confronted with new imaging tools aiming for more accurate diagnosis and sparing patients the long list of money and time-consuming protocols. In clinical practice, multimodality algorithms have been widely applied for whole body imaging, including conventional X-ray, ultrasonography, skeletal scintigraphy, CT, MRI, and PET-CT. And of course, the upcoming era of PET MRI. The world is now heading towards a new era of one-stop shop examinations. Now, if we are comparing a whole body MRI, we could compare it to a multitude of imaging tools, which in a single setting, the patient will gain all the knowledge or all the information needed as regards bone, soft tissue, and nodal lesions and properties. In comparison to regional MRI, a bone scintigraphy, X-ray, a CT study, regional CT study, because it's not applicable, or not applicable, it's not preferred to perform a whole body CT study for a patient, and the ultrasonography. Then, what appears to be comparable to the whole body MRI would be the PET-CT, which also weighs to these techniques. But actually, these two techniques don't weigh to the other techniques I mentioned, because a conventional radiological study, an ultrasonography, a CT study are only qualitative tools, descriptive tools. But when compared with the MRI to PET, we are including both qualitative methods and quantitative methods. It's a functional tool as well as an anatomical and descriptive pathological tool. Whole body MRI simply includes coronal T1 weighted images, stare, and WIPs. Now this is the established protocol, but some modifications could be applied according to the need and according to the triaging the patients and selection of a definite protocol for each patient. Now, the applications of whole body MRI, by far the most important, is staging of malignancies and their metastatic load in a single examination that could be performed without any need for IV contrast to assess the, as I've earlier mentioned, the soft tissue, osseous, and nodal metastatic load, monitoring response to therapy, detection of tumor persistence or recurrence in comparison to benign post-surgical therapeutic changes, assessment of multifocal disease in other settings than malignancy, like multifocal osteomyelitis, multiple hemangioma, Langerhans cell histiocytosis with multi-body affection. There is also the whole body MR neurography I showed in the previous presentation, and whole body MR angiography. Since the main topic would be that of the role of whole body MRI in metastasis, so I'm just showing examples of the non-malignant applications of whole body MRI, like this case with multiple hemangioma. Now, there is a subcutaneous hemangioma here. These are hemangiomas. Of course, the study is including the T1 and the fat suppressed, and when needed, and the diffusion, of course. And when needed, contrast could be administered. Accordingly, these were characterized to be hemangiomas. Also here in the head and neck region, in the liver. This is the whole body MR neurographic study, which has its role in the multiple affection disorders like the multiple neurofibromatosis. And then we got the whole body also angiographic studies, which could help in the when there's this systemic involvement of vascular malformations. The benefits of whole body MRI include the high image resolution, capability to detect osseous, nodal, and soft tissue lesions, being of both qualitative and quantitative values through the integration of diffusion-weighted imaging and IV contrast in a dynamic fashion with creation of perfusion maps, sparing patients the performance of multiple studies that are both time and money consuming, also sparing them the exposure to ionizing radiation, and it is also the modality of choice in the renally impaired patients and in children and in elderly and in pregnant women who are going to perform a regular follow-up study for follow-up of malignancy or a multi-system affection in other diseases or disorders. Now, cancer is the second leading cause of death in developed countries and is among the 3 leading causes of death in developing countries. Once a malignant tumor is detected, determination of disease extent is important for appropriate treatment planning and determining the prognosis. Imaging plays a pivotal role in cancer staging, in monitoring response to therapy, and in the detection of tumor recurrence and differentiating it from benign post-therapy changes. All existing imaging methods in detection of skeletal metastasis have certain limitations. Now, we are going to talk mostly about scintigraphy and bone scintigraphy and whole body MRI. So as far as scintigraphy is concerned, it has long been the standard for detection, and it still is, for detection of bone metastasis. It helps in verifying metastatic bone deposits through the absorption of the methylene diphosphonate onto fresh hydroxyapatite crystals that are released with the osteoblastic activity. And so accordingly, it is more sensitive to the osteoblastic metastasis than the osteolytic metastasis. In terms of osteolytic metastasis, it will only be an indirect marker through the surrounding osteoblastic reaction that occurs on top of surrounding an osteolytic lesion. In the absence of such reactive osteoblastic activity, lesions appear as focal cold spots, which are often difficult to recognize, especially if they are small in size. As for MRI, it is known for its high spatial resolution and its capability to detect early mallow lesions, but due to its limited coverage, it was only used for regional assessment of equivocal lesions and non-visualized lesions on other imaging modalities. From here came the importance of performing a whole-body MR survey. With the recent advances in hardware technology, including rolling tables, and integrated the TIM here, which helps to a type of parallel imaging, and integrated coils, whole-body MRI has become feasible at reasonable scanning times. Diffusion-weighted imaging has been introduced to MR sequences in the mid-50s, and since then the diffusion-weighted imaging has been a fertile environment for research, rendering MRI not only a descriptive qualitative tool, but also a functional tool, assessing lesions and abnormalities at a cellular level. Now we are going to just shed light on rapidly on the pathogenesis of bone metastasis. Bone is one of the most common locations for metastasis. While any type of cancer is capable of forming metastatic tumors within the bone, the microenvironment of the marrow tends to favor particular types of cancer, including prostate, breast, and lung cancer. As a metastatic lesion grows in the medullary cavity, the surrounding bone is remodeled by means of either an osteoclastic or osteoblastic process. And from this, the imbalance between the osteoblastic-osteolytic reaction results the predominance of the type of the metastatic lesion, be it a lytic or a sclerotic or mixed lesion. Metastatic bone involvement occurs by any of these means. We all know it's either direct or retrovenous or seeding. And there is a term known as latent bone metastasis, which is seen encountered with breast cancer. The patient can have breast cancer, and in the initial setting she has no metastasis. She performs whatever surgery, takes her therapeutic regimens, and then say after up to 10 years she can come back with metastasis, although the primary is not there. Metastasis may arise years after removal of the primary tumor, and the mechanisms allowing latent disseminated cancer cells to survive are still unknown. There are postulations and some theories trying to configure it. Now, imaging in bone metastasis. As for radiography, it is known that there has to be a certain level of altered mineralization or demineralization for the lesion to appear. As we can see here, there is an osteolytic lesion. It is a sizable lesion, and that only diffuses sclerosis of this lumbar vertebra. But then if we are talking about subtle marrow lesions, definitely they would be missed on radiography. Then we've got on CT. It is also, it's a more sensitive tool, but then again, if we are talking about subtle marrow changes, again, it won't be that, it won't be the modality of choice. And then it also has a role in the, another diagnostic role in the guidance of biopsy taking from different lesions. As for bone scan, the scintigraphic patterns encountered in skeletal metastasis include a solitary hot focal lesion, multiple hot focal lesions diffuse involvement with the metastatic superscan, or cold lesions in the osteolytic metastatic deposits. Maybe it can be normal. This is a false when it's false negative. And there is what is known as the flare phenomenon on follow-up studies, and together with the extraskeletal tracer uptake. Now, as we can see here, there is the multitypical appearance of bone metastasis, where we can see there are multiple asymmetric involvement of the bones of the skeleton, the axial skeleton and the appendicular skeleton. Then we can see this is the metastatic super scan, where we can see there is a delineation, of course, with an element of asymmetry. There is delineation of all the bones of the body, with a heavy uptake of the tracer. Then we've got, this is an osteolytic lesion attributed here. Now there is an area of photopenia seen. What helped in this visualization of the lesion is the incomparability between both iliac bones. We can see here the rim, the blade, while here it is indistinct, and then we've got this definite osteoblastic reaction. If this was a small lesion, it could have most likely been missed. Then we've got an example of extra-osseous uptake in these necrotic metastatic deposits in the liver, showing increased tracer uptake at the right hypochondrial region. Then we've got the flare phenomenon, which is seen within 2 up to 6 months in follow-up studies after chemotherapy. Now the idea here is that the patient has a certain small focal, in response to chemo or radiotherapy, we can see that there are small lesions along the spine, and then in the follow-up study they became flared out. This is actually a response to therapy or an attempt of the bone to heal by forming new bone, by sclerosing. And so this osteoblastic reaction could be misinterpreted as a progression of the disease process, where actually, according to the RISIS criteria, it is considered a partial response. Role of PET in bone metastasis is still, there is still debate. But what is for sure is the selection of the radiotracer used, where the fluoride PET is, shows a superior quality in the detection of the lesions. Now this is the same patient at the same setting. We can see an FDG PET shows some of the lesions, while actually the patient has a much higher metastatic load. Then we've got MRI in bone metastasis. Typically, we all know that a metastatic lesion, a typical metastatic lesion would be dark on a T1 weighted image, inhomogeneously bright on a fat suppressed sequence. And then we've got what is known as the halo sign. Okay? Now there is the bullseye sign. This is a benign lesion where we see a central hyperintensity surrounded by a hypointensity, which is within the spectrum of the degeneration. There is preserved marrow fat. This is seen on T1 weighted images. And then we've got the halo sign, which is a typical malignant sign of a sclerotic lesion, hypointense on fat suppressed sequence surrounded by a halo or bright halo of marrow edema. But of course, not all lesions are typical. There have been other tools introduced for the better characterization of marrow lesions. Like you can see here, this is the in-phase, out-of-phase sequence. Now, can you see a lesion here? I don't really think it's that distinct because there is overall hypointensity of the marrow. But then when we perform the out-of-phase sequence, we can see the normal drop of signal in the fat of the marrow, while here there is no loss of signal, which helps us in distinction and pointing out a lesion. There is also the fat suppressed sequence, which have the diffusion weighted images, which help in pinpointing and lesions that could be indistinct or not appreciated on the other conventional images. Then we've got the contrast enhanced MRI. Now, as I've mentioned before, a whole body MRI is performed without, normally performed without an IV, without the need for IV contrast. Yet the indication of, the only indication of IV contrast would be if there is suspicion of, as we can see here on the T2 weighted image, there is a lesion here. This is an intramedullary metastatic lesion, intraspinal within the cord. And then when there is suspicion of an extraosseous soft tissue component. We got the diffusion weighted imaging and bone metastasis. Now, the physical principles, I guess we all know of diffusion weighted imaging and ADC mapping. Now, diffusion weighted imaging is sensitive to the random Brownian motion of water molecules. In normal biologic tissues, the presence of impeding barriers like the cell membranes, the fibers, and the macromolecules interfere with the diffusivity of water molecules. Now, these impeding barriers vary from one tissue to another, and this is what creates the variations in signal on diffusion weighted images between, let's say, the normally restricting organs and the normally facilitating organs, starting with the spleen, the prostate, the nerve fibers. They are all normally restricting organs. And then we got the normally facilitated organs like those which contain the fluid, like let's say the bowel, the gallbladder. This is the extreme from one direction, this is the other extreme from the other direction. Pathologic processes that alter the physical nature of these restricting barriers affect the diffusivity of water molecules. Now, this is just an example showing the normal diffusivity. We can see that there is a normal cellular density here. There's no cellular packing, with the normal diffusivity of water molecules between the extracellular compartment and the intracellular compartment, giving us this image. If we are going to compare this to this image, there is, due to the cellular packing, there is impedance in the flow of the water molecules between the extracellular compartment and the intracellular compartment, resulting in this signal abnormality, which is known as the diffusion restriction, with the multiplicity of these lesions seen along the bone as well as lymph nodes due to the cellular packing with subsequent impedance of water diffusivity. There is both qualitative assessment of diffusion weighted images, which we have just seen to see a diffusion restriction or altered diffusion behavior, but then there is also the quantitative assessment through, this is a colored ADC map with a grading of colors from blue to red. Now, this quantitative assessment is through what's known as the ADC value, with ranges of ADC values met with in different regions. Of course, this was my MD thesis. I'm going to skip this. There were about 60 patients. All of them were subjected to clinical history, a static bone scan, and whole body MRI. This is the protocol. As I've mentioned, the typical protocol included the T1, the stare, and the diffusion weighted images. In some cases, they were administered IV contrast. And these were the results. Now, according to these results, I removed many of the slides, but I just put these to show the comparability and the difference between whole body MRI and bone scan. Then again, comparing the whole body MRI without diffusion and with diffusion. I'm going to tell you, let's skip this, I'm discussing it later on. There was what I concluded from my study is that the addition of diffusion-weighted images played a major role in the detection of more lesions that were less conspicuous on diffusion on the other conventional MR images, and were furthermore not distinct on the bone scan. Yet, there is another issue, is that there is the demographics. Now, according to the distribution, bone scan was preferably detected more lesions as regards the skull, the calvarium, and the rib cage, while MRI detected more lesions as regards the appendicular skeleton and the pelvic bones. The issue was, as regards the ADC values, is that there is an overlap between the low ADC values of normal red marrow and metastasis due to the comparability of the cellular packing, giving a range of lying between the range of 0.621 to 0.69. Then there was another overlap between metastasis and other benign pathological marrow entities within the range of 0.9 and 1.03. The mid-range of 0.7 to 0.89 was spared for only metastatic lesions. But again, I can conclude that this is definitely the cutoff. Whenever I see an 0.7 or 0.8 lesion, this means it has to be a metastatic lesion. You have to rely on the other tools, not just the ADC value. I can also conclude that ADC could play a major role in the follow-up. We can consider this a baseline. These values could be considered a baseline. And then on follow-up, if the patient is responding or not, this will be concluded through the rise or the decline in the ADC values. Then there is the detection of soft tissue lesions. Again, the diffusion came superior, the addition of diffusion to the whole body imaging rendered it more superior in the detection of some of the soft tissue lesions. These are examples of some of the cases. Now, this is a 45-year-old female patient who was recently diagnosed with breast cancer. No surgery or therapy was done prior to her studies, the bone scan and the MRI. Her presentation was of agonizing lower back pain and right sciatica. Now, as we can see here, this is the bone scan. We can see that there are suspicious hot lesions at the lumbar spine and also at the upper dorsal, let's say D1 or D2 level to the right. Now, this was on the bone scan. This is her MRI. Of course, I took selected images. On her MRI, we can see that this is a coronal diffusion-weighted image showing the bulk seen at the lumbar. Those are the kidneys. Okay. This is the bulk of the osseous lesion with a soft tissue component protruding to the right at the level of L2 vertebra. This is the lesion here with expansion of the bone and the soft tissue component. This is its T1 signal. And then we can see that there is another lesion here, but yet there's another lesion here. It's at C4, C5, which was not detected because it's a small, discreetly seen within the marrow, and most likely there is no, it's beyond the scope of this bone scan study. This is the same patient. This is the primary breast lesion, because as we said, this was the initial setting. The diagnosis was just about a week before we performed the studies. With the diffusion restriction encountered as regards. This was a typical MR feature of irregular outlines of the breast lesion, diffusion restriction, and it also, in this study, we found pulmonary metastasis. This is another case, a 51-year-old female patient with breast cancer. Conservative lumpectomy with a safety margin and axillary clearance was performed. The lymph nodes were negative for metastasis. She received chemo and radiotherapy. She was tumor-free for 3 years prior to her current bone scan and MRI. She had generalized bone aches. This is a case of latent metastasis. There is a heavy metastatic load asymmetrically implicating mainly the axial skeleton. We can see a lesion, a calvarian lesion, several calvarian lesions, and also a lesion seen at the right femur. As for her MRI, now this is one of the cases where MRI wasn't beneficial, because as we can see, there's a diffuse hypointense signal of the marrow, and then there's the diffuse mottling of the marrow on the stair sequence, and this is her diffusion study. Now, we can't point out a lesion, and the whole marrow is involved. But actually, this patient had a yellow to red marrow reconversion. She had dense red marrow because she had chronic anemia. Now, this is one of the pitfalls of MRI. Now, the issue is here that you are either going to call this a diffuse infiltrative process, diffuse metastasis, or myelomatous affection, or a benign entity as a red marrow. In this setting, you definitely can't call it with confidence either or. So this was defective. This part of tackling of marrow lesions, it was defective in this study, and that's why I say it's important when we find cases like this to perform a more dedicated MR study with more tools like the T1, the T2, the M-Dixon, and the contrast maybe studies to help improve the detection. But then again, a bone scan was more superior in this case at this setting. We can see there was a soft tissue deposit here, and there were more lesions detected as regards the femoral. So we can say that they completed each other. Both studies completed each other. Then this is another case, a 58-year-old female patient with lung cancer. Biopsy was taken verifying small cell lung cancer. On initial presentation, patient had no metastasis. She took chemotherapy for a year prior to the current bone scan and MR studies. There was no surgery for radiotherapy. She had left pelvic pain and cuff swelling. Now this is her bone scan. Now there is abnormal tracer uptake seen at the left iliac bone and acetabular region. But then again, there is a somewhat metabolic super scan with the tie sign and the calvarial, diffuse calvarial and facial bone uptake. And then again, there is the abnormal soft tissue uptake at the cuff regions bilaterally. This is her MRI. Definitely there is the infiltrative process implicating the left iliac bone, but then again there is involvement also of the left femoral neck and proximal shaft, which is not that well appreciated on the bone scan. There is also another lesion at the right iliac bone. It's faintly seen here. This is the primary lesion. And then this patient had a metastatic, soft tissue metastatic lesion at her left cuff muscle. Now, this is not explaining this metabolic super scan, nor is it explaining this diffuse subcutaneous tissue uptake. Now, this was later on explained by having a hyperparathyroidism, and this was a paraneoplastic syndrome secondary to the small cell lung cancer. So in this case, we can see that, again, MRI played a role in detection of the soft tissue affection, but then the bone scan showed us this raised the suspicion of there is something else happening in the body, and actually this was explained by the hyperparathyroidism. A 38-year-old female patient with right breast cancer. Patient was already with hepatic and osseous metastasis at her initial staging. Patient had been on chemotherapy and she received radiotherapy for vertebral metastasis. She was still on therapy while performing her current bone scan and MR studies. What she was presented with was newly presented with was excruciating persistent occipital headache and drooling of saliva. Her neurological examination revealed right unilateral hypoglossal pulse. This is her bone scan. Now we can see that there are multiple metastatic deposits, and this one is of major importance because this one was missed on the MRI. This one was not detected on the MRI. As for the other lesions that were seen, and we can see on the whole body T1 weighted image, there are the multiple hepatic lesions, metastatic lesions, the multiple osseous lesions, but then there's the detection. What's added by MRI was the detection of this epidural metastatic deposit with compressive effects on the cord. The patient also was found to have brain metastasis, and then we can see also the osseous metastasis implicating the right ala of the sacrum. Now, based on the MRI findings, we wouldn't have an interpretation or an answer to the patient's current symptomatology of the excruciating occipital headache and the drooling. But by this lesion, these are the hepatic, but by this lesion that was detected on the bone scan, and that's why I said at first that the sensitivity of bone scan in the detection of calvarial and rib cage lesions is much higher than MRI. This was a metastatic lesion that is seated at the occipital condylar region, implicating the course of the hypoglossal nerve through the hypoglossal canal, according to the anatomical location. This is the last case I'm going to show, a 51-year-old male patient with left lung cancer. The patient was subjected to surgical resection and chemotherapy. He had no metastasis and remained tumor-free after therapy for 2 years. The left lung malignancy recurred, for which he was put again on chemotherapy. He has been on chemotherapy for 4 months prior to the current bone scan and MRI studies. His current presentation at time of performance of these studies was chest pain. This is an example of the better delineation and distinction of these rib lesions. There's nothing else seen here, and again this was confirmed by MRI. The patient had pleural nodules, but the exact delineation and distinction of these bone lesions were not detected on MR study. We can see the primary lesion and the subsequent consolidation collapse. There was another peripherally located metastatic nodule of diffusion weighted image. The patient also had adrenal metastasis. So again, MRI played a role in detection of the soft tissue metastatic load, while the bone scan showed the osseous deposits at the rib cage. And so again, they both complement each other and are important, and are both similarly important. This was an incidental finding of a hemangioma in the liver. To conclude, based on our statistical values, we concluded that bone scan has a higher accuracy in the detection and characterization of calvarial and thoracic lesions, while it wouldn't be the first modality of choice for appendicular lesions. On the other hand, whole-body MRI has a higher accuracy for the detection and characterization of pelvic and appendicular lesions, while it wouldn't be the modality of choice for calvarial lesions. As for the thoracic lesions, we found out that diffusion-weighted imaging improved their detection through the 3D MIPS and MPRs and the thick stack MIPS. To sum up, we don't think that whole-body MRI should replace bone scan detection of skeletal metastasis. We believe that whole-body MRI should be the modality of choice when both skeletal and soft tissue metastasis are suspected, and in the follow-up of known metastatic patients. Whole-body MRI, as I earlier mentioned, would also be the modality of choice in case of chronic renal failure, pregnant patients with metastasis. The combined qualitative and quantitative features of diffusion-weighted imaging help in the assessment of tumors at the stage of initial characterization and in the follow-up of lesions verifying response to therapy at cellular levels, even prior to gross morphological changes. Now, this is an algorithm triaging the patients. Now, Initially, the patient will perform a bone scan according to the guidelines, but then for osseous, or the initial staging of osseous metastasis in prostate, lung, and breast cancer. Now, in case of negative findings without symptomatology, then it is preferable to do a whole body MRI rather than a regional MRI according to the symptomatology of patient. When it's not there, then PET could be done, but again, I'm recommending that a fluoride PET to be done, not an FDG PET. Okay. Then, when there is clinical suspicion at start of osseous and soft tissue metastasis, then by far the whole body MRI with diffusion would be advised, comparable to the PET according to the availability and cost issues. Now, the choice, would be between them according to availability and price or cost issues. For follow-up, bone scan is not recommended before 6 months, 12 months, before 6 months post-chemotherapy to avoid the misinterpretation of the flare-up phenomenon. Diffusion-weighted images are as sensitive to post-therapy changes as early as 1 to 3 months. PET-CT is an accurate functional tool helping follow-up based on metabolic activity, but as I've mentioned, it would be sensitive to the soft tissue affection rather than the osseous affection in light of the available radiotracers used. As for metastatic hepatic and renal cancer with a predominance of osteolytic metastasis, then from the start a whole body MRI or a fluoride PET would be advised, because from the start we will be missing lesions that will not be detected on bone scan. Also those with chronic renal disease, end-stage renal disease, pregnancy, and preferably in the pediatric age group, then a whole body MRI with diffusion for staging and follow-up would be advised. Thank you.